Hi, everyone. I'm Mikkael Sekeres, Chief of the Division of Hematology at the Sylvester Comprehensive Cancer Center at University of Miami in the United States. And I'm going to talk about what factors contribute to our assessment of quality of life in adults with myelodysplastic syndromes. Quality of life is extremely challenging to measure formally. We typically rely on a variety of different types of instruments. When we say instruments, we mean questionnaires where we ask people, for example, broad questions like, how are you feeling? Or we may ask very specific questions like, do you get short of breath when you go for a walk or climb stairs? Myelodysplastic syndromes affects people at an average age of about 70 years. So when we talk about quality of life in people with MDS, we have to actually adjust that for what population norms would be for people in their 70s. People with myelodysplastic syndromes tend to have cytopenias. So they may have anemia, a low platelet count or thrombocytopenia, or a low white blood cell count, specifically neutropenia. Those low blood counts actually contribute to quality of life in people with MDS. Someone who has anemia may have a poor quality of life because he or she is short of breath, may have a loss of appetite, may get headaches, and may just in general not feel well. Somebody with a low platelet count may have a quality of life that's compromised because that person has episodes of, for example, nosebleeds or gum bleeding or bleeding from their GI tract. And somebody with neutropenia, a low white blood cell count, may just in general not feel so great and not have as much get up and go. We hope that when we start treatments in people with MDS, their quality of life improves, but it's actually extraordinarily hard to measure. And the reason is that if you imagine a clinical trial where half the people receive an experimental drug and half the people receive placebo, and then the efficacy of those two approaches is measured over time, even if the drug works and a person who was previously anemic is no longer anemic, that person's quality of life certainly should improve. But the folks who are getting placebo are continuing to get blood transfusions on that same trial. So when you measure quality of life in them, it may be just after they received a blood transfusion and they're feeling relatively well, as opposed to just prior to that blood transfusion where they're not feeling as well. So there are very few studies that have been randomized that have shown an improvement in quality of life for an intervention versus another. And to my knowledge, there are no studies that have very clearly shown an improvement in quality of life that have been blinded. In other words, where the people who've been randomized to the control group have no idea whether they're getting the active drug or a placebo. So we continue to explore this and believe that quality of life and improvement in quality of life is absolutely essential for new therapies used to treat people with MDS. I think the future of quality of life assessments, beyond having questionnaires that are very specific to the needs of people with MDS, is to focus on what are called wearables. In other words, an Apple Watch like I'm wearing, or a Fitbit or Garmin device that can measure how active people are when they're at home, how many times they're lying on a couch versus out going for a walk, where they can record how much of a meal they're eating, and also how many times they have to visit a clinic or go to the hospital. Thanks so much for listening today.